Good morning. Good morning, everybody. Welcome to the VACCRA monthly meeting, one you will have questions about and will enjoy. But before we get started with our guest speaker, I have a couple of announcements that I think you might be interested in. The first one has to do with membership. Guess how many members we have?
Over 100, over 200.
210. We would love to get to 225. Always reach, always reach. Who would like to help us to get to 225? Great, good. Any other hands? Come on, raise your hand. Help us get to 225. We happen to have, in case you know someone who is not a member, we happen to have outside on the table applications for membership. Please pick up one if you know somebody you would like to talk to about joining VACCRA.
About joining what, please?
VACCRA. Us. I want to mention changes of address. There are folks who have moved from the cottages to apartments, from apartment to apartment, or to a different level of care. It's important that you change your address with VACCRA when you do that. So please remember to do that. In February, VACCRA held a coffee for new residents. Many of our officers and board members attended that and talked with new residents, and guess what? We got new members, which is great. We're going to have another coffee for new residents in early summer, possibly June, I'm not sure yet. If you've ever wondered what the state VACCRA does, or what they have done, or what they're all about, you will have the opportunity next Friday at 10 o'clock in this room. Please come to the state spring VACCRA meeting. It'll be by Zoom. We have a wonderful speaker, Dana Parsons, who is the Vice President and Legal Counsel for Leading Age. She is going to give us this year's General Assembly overview and will be available for questions. It's going to be an interesting meeting. We hope that you can come to this Zoom meeting. And now I'm going to turn this over to Barbara Rose.
Good morning, everybody. It is sunny, warm, and spring has sprung, I do believe, and off the track ad. Pickleball nets will go up at the end of March, and then we'll have an open house. But back to this morning. We're so happy to have Dr. Chuck, is Charles, but he goes by Chuck Webb with us. He's a retired physician with an interesting mix of background in his career. He was a Peace Corps volunteer, setting up an education program to teach tropical diseases in Cameroon, French West Africa. He trained. Is there a way to stop the feedback? Or do you not hear it?
We hear it.
Okay.
Maybe you're too close to the mic.
Okay. Anyway, to start again, he did Peace Corps in Cameroon, French West Africa. Okay, trained in internal medicine at Ohio State Med School, and then he was a hospitalist there.
Barbara, we really can't hear you.
Okay, so it has to be, there's a happy medium.
Talk loud.
Talk, I can do that. Okay, so maybe it likes a lot. Sorry for all this confusion, but it's driving me crazy. Okay, he was Associate Chief of Staff at a Veterans Hospital in Hampton. That's when he started to live in Virginia. He became a geriatrician and took over a nursing home and hospice there. He retired early from the civil service, and he never stopped learning. He loves learning. He trained board-certified internists to become board-certified gerontologists. And he currently lives in Covenant Woods. And that happened because he has children here. So after being in Norfolk and Eastern Virginia, that's what he did. And he did one other thing after the medical career, and I'll let you him tell you about that. It's from another university, another degree. Take care. Welcome, Chuck.
Thank you. I got a Master of Divinity. That's what the MDiv stands for. I went to Union Presbyterian Seminary after I retired, and it was a wonderful experience. So that's my... So we're going to talk about traditional Medicare. Everyone here has Medicare, I'm pretty sure, and most people are happy with their coverage. That includes both traditional Medicare and Medicare Advantage. So my first goal is going to be to show you the difference between traditional Medicare and Medicare Advantage. My second goal then will be to explain ACO REACH, which is a new program. You need me for anything? No. So the Centers for Medicare and Medicaid Services wants to privatize all of Medicare by 2030, which means we would all be under a Medicare Advantage kind of program. So that's going to be the second part of the talk. So that's the reason for the title, Traditional Medicare is Under Attack. So let's see if I can do this now. I have to turn it on. Yes, sir. Now, all right, good. So Medicare today is currently in two types of coverage. One is indemnity health insurance, the other is privatized care. Indemnity means to protect individuals from financial loss. So it's a program that covers medical care primarily when you get really sick. This is the kind of Medicare that you want to have, traditional Medicare. It covers what the doctor orders, fee for service, diagnosis, therapy, treatment, everything is covered under traditional Medicare. If you have the Medigap or the supplemental insurance, it costs you next to nothing. Privatized care or Medicare Advantage is a company that inserts itself between the government paying and the doctor treating. It's a wonderful program as long as you stay healthy. The real problem, as we'll see, is when you get really sick, they don't have the money to take care of you, and so they find ways to deny your care. Okay, louder. All right. Thank you. So the average that Medicare Advantage gets for a year is $15,400 for the typical senior. That's divided into monthly installments of about $1,300. So that each month they have money to take care of you, but then with some of these really serious illnesses that take a lot of money. They're not, it's not there to take care of. So they deny requests, limit referrals, and refuse payments. That's, okay. So before Medicare started in 2065, about half of seniors didn't have health insurance, and there was a real problem with either denying care or going into debt. So Medicare solved that, and the initial amount of money spent was $7.5 billion. It's grown rather dramatically. By 2020, it's $925 billion. This year, it'll be $1 trillion. So it's, and then on the other side, we had a little less than 20 million seniors or people on Medicare, and that has grown sort of more linearly. 65 million beneficiaries in 2022. 9 million of those are the disabled that are usually less than 65, and 6% or 56 million Americans are the seniors. So you can see we're talking about a huge program. It's not really easy to conceptualize or talk about such a big program, but we're going to do it. So physicians like to start with case studies. So I'm going to talk about two cases. The first is a resident of Governor Woods with metastatic melanoma. Received all the diagnosis and several consults, and they put him on immunotherapy, which costs $23,000 a month. It's what Jimmy Carter got, and he's in remission and doing well. And the second case is a brother of one of my neighbors who spent several weeks in the hospital for a serious illness. About a year before this, a salesman talked to him about Medicare Advantage and convinced him that the whole country was going in that direction and he should get in early. So he signed up for Humana Medicare Advantage. So after being sent to the nursing home for rehab, after a few days in the nursing home, Humana informed the nursing home they were going to stop paying. So he was being too sick to go home. He paid out of pocket, lost his home, went on Medicaid, became very depressed, sort of gave up, went into hospice and died about 2 weeks ago. So this is the kind of thing that we're going to see. So traditional Medicare is simple and efficient. That's shown by the two green arrows, they're sort of green there. The doctor orders, the people do the procedures, and Medicare pays for it. And there's also now Part D, pharmacy, and then supplemental insurance. So we got 4 different parts. So let's talk quickly about the 4 parts of Medicare. Part A is the hospital insurance. If you've worked 10 years paying into that Medicare tax, the 1.45%, and then the employer puts in 1.45, 10 years of that, and Medicare A is covered, except for the deductible when you get hospitalized. There's a $1,600 copay when you get admitted to the hospital. And if you got Medigap insurance, it pays that. So Part B then is the physicians, the outpatient, the nursing home rehab after 3 nights in the hospital, other expenses. It costs $174.70 a month and covers 80% of expenses. It's more expensive if you're at a higher income level, but that's, or as you get older. Part D then covers the pharmacy. It was the relatively new 90% of beneficiaries purchase Part D at a cost of about $55 a month. And then supplemental insurance, Medigap insurance, called Medigap because it fills in the gaps in Medicare. It's the fourth type of coverage. 80% of traditional Medicare have the Medigap insurance. Most sign up for a Part, I think it's Part G, which pays co-pays and deductibles, costs $135 a month. All right, so now this next slide. This is probably the most important slide to have in your mind. It shows the beneficiaries on the left and the program spending on the right. So if you focus on the top 5% of Medicare recipients, Medicare beneficiaries, they take 42% of the Medicare budget. So 1% and 4%, you add the 15%, 27%, 42% of the Medicare budget. So each of those recipients is going to cost $102,000 a year, 1.7 million people. And that's the real problem with Medicare Advantage, because Medicare Advantage is going to the government and saying, we've got this patient that's this sick, and the government says, all right, here's, that's a sicker patient, we'll give you maybe $30,000 for the year to take care of that patient. But it's not going to cover the expenses for those really sick 5%. So the remaining 95%, if you put them all together, is about $7,500 a year. If you break it out, the next 20% is $25,000. The following 25% would be $6,000 a year. And the bottom half of Medicare patients cost less than $1,000 a year. So you can see if they're getting this money, why it's easy for them to give you free eyeglasses and hearing aids. And we're talking about the fee-for-service statistics, but it's probably comparable in Medicare Advantage. The problem is Medicare Advantage just doesn't give us reports like this because, as we'll see, it's a very complex system with lots of companies and lots of... All right, so what's the source of funding? In 2021, in the center there, you can see that the premiums we pay only covered 15% of the Medicare budget for 2021. The general fund, or the general taxes, is 46%. The Medicare payroll tax, the 1.45% that workers pay and employers pay, made up 34% of the income for Medicare. Now, the Medicare payroll tax is going to run out of money in 2031. That covers the hospital. You can see the number of workers is decreasing, so the Medicare payroll tax is decreasing at the same time that the number of seniors is going up. By 2030, and the baby boomers retire, there'll be 80 million on Medicare. So you have more people and less income. So Congress is going to have to do something. It's clear either that or Medicare is going to be having to make some decisions. So Medicare Advantage is a health maintenance organization. In the private sector, health maintenance organizations haven't done very well. The reason being, when they deny care, there are lawsuits and they tend to be not very well accepted. But in the government, with Medicare, you really can't sue the government, and so there's no lawsuits. So half of people now have Medicare Advantage. HMOs are designed to be cost-effective maintenance kinds of health care. They hire their own physicians, and they limit the number of consultants that can be used. And whatever they don't spend on your health care is called profit. And so their motivation is to spend as little as possible to maximize their profits, and then that money goes back to the shareholders. With health insurance, that money would not go back to shareholders, it would be saved up in a pot for the people that get really sick. But that's not true in health maintenance organizations. So 58% of Medicare Advantage programs are pure HMOs. 40% are called PPOs, or preferred provider organizations. They permit more out-of-network consults, but at a higher cost. And then the remaining 2% are special needs programs. In an HMO, one primary doctor usually serves as the gatekeeper. There's a limited number of consultants, and a referral is needed to see a consultant. When the physician determines that something more intensive is required, he turns to the company for advice, and the company tells him whether they will or will not pay for it. They often suggest temporizing measures, so the doctor orders an MRI. A woman is in the emergency room, she can't walk with severe hip pain. He needs an MRI to know what's going on, and the company says, well, we'll pay for a plain X-ray. Then instead of surgery, we want you to do 2 weeks of rehab first. So denials are common, 1.5 million denials in 2021. So the company is actually in charge of treating the severe patient rather than the physician. So here you have Medicare Advantage, which is complex and inefficient. There's an average of 8 different companies and 43 different plans in each county around the country. So the average payment of $15,400 covers most of the healthy people very effective. The bottom 75% extremely well. It's also used to offer extra benefits, hearing aids, gym memberships, groceries, even in some people paying their premiums. It's also used to buy all the advertising that we see on TV and the political influence. An agent who sells a senior on Medicare Advantage, let's say you say, all right, I'm going to switch from traditional Medicare to Medicare Advantage. That agent makes $600 from the company that they make that switch on. And every year that you renew in Medicare Advantage, they make another $300. So the agents really have a big interest in selling you on Medicare Advantage. Here are the Medicare Advantage companies. You can see United Healthcare is the biggest at 28%, and then Humana and Blue Cross Blue Shield plans, so that those three make a total of about 60% of the Medicare Advantage plans. Then you have a number of smaller ones, CVS, Kaiser, Centene, Cigna. The 16% other insurers, they said that that's mostly state-run Blue Cross Blue Shield programs rather than the national coordinated one. So we have two models of Medicare. Traditional fee-for-service, the physician is in control, and they have deep pockets. Medicare Advantage, the company is in control. They offer excellent primary care and benefits and prevention. The Medicare, traditional Medicare, you have the supplemental insurance. There's no supplemental insurance available for Medicare Advantage. It's much cheaper, $4,200 versus $2,400. That was last year's statistics, but it's about the same, about $2,000 cheaper. So you have a number of seniors who have not planned for their retirement and are living on mostly Social Security on very low income. So to them, Medicare Advantage is really the only thing that they really can afford. And then tertiary care, if you've got traditional Medicare and you need an opinion from Duke or Hopkins or the Mayo Clinic or one of the, MD Anderson, under traditional Medicare, that's no problem. You call them up, make the appointment, they ask you what insurance you have, you tell them, and they schedule your appointment. If you've got Medicare Advantage and you want to do that, the company's going to say, I'm sorry, you have to stick with the consultants here in our program in Virginia. And you say, well, I'm going to go to MD Anderson anyway, and they say, well, that'll be private pay. MD Anderson will look at your Medicare Advantage and say, I'm sorry, we don't take that insurance because they won't pay us. So if you're going to come, we want upfront half of what we think it might cost. So traditional Medicare costs 1.4% overhead, which is the administrative fees. Medicare Advantage on the party line costs 15%. There are different ways of looking at this. A lot of people have said, let's look at what these companies are really spending for health care, and they find that they're not spending 85% on health care. They're spending more like 70 or 75%. So the overhead and profits are probably more in the 25% range. So if Medicare is $1 trillion this year, Medicare Advantage will be about $500 billion. And as you can expect in a situation like this, not very good at this, situation like this where the companies have the ability to charge and make a profit. Here's an article that says they're making $140 billion in 2023. Most widely accepted is $88 billion. To compare that with other things in the government, the whole NASA budget is $30 billion. So this is 3 to 4 times what the government pays NASA. All right. So they have enough money to influence politics. They have about 200 lobbyists working in Congress. And we're going to discuss in our next meeting, there was a letter signed by 61 senators extolling the virtues of Medicare Advantage. Okay, so another way of looking at how much money they're making is how much they pay their CEOs. This Molina healthcare company, he's paid $180 million a year as his salary. The others, Cigna, CVS, Aetna, Humana. Elevance is the new name for Anthem Blue Cross Blue Shield. They changed their name. United Healthcare, Centene. Another study that's not shown here looked at 300 publicly traded healthcare companies, added up how much they pay their CEOs. It came to $4 billion. The salaries that are being paid to the CEOs. Now we contrast that with 100 million Americans who really are saddled with medical debt, some seeking bankruptcy, a third of seniors having trouble paying for their medical care, 30% skipping medicines or not seeking care at all to save money. They're faced with the question of, do we eat or do we buy medicines? it's reported that 10% of seniors actually have only Part A Medicare and can't afford Part B, and some of them have no coverage at all. So it's interesting to see the Medicare business model. So if you're a Medicare company, you're going to try to enroll those healthy 75 or 95% of people that aren't going to be so expensive. That's called cherry picking in the industry. And one company put their office at the top of a flight of stairs, and only the Medicare recipients that could climb up would be enrolled. Then you upcode, that'll be shown on the next slide. So you take a patient's chart and you try to make them look as sick as possible so the government gives you as much money as possible. Then you use that money to offer extra benefits to make the program as attractive as possible. When you have to, you cover medical expenses and fees. You advertise widely, and you try to avoid discussing the limitations. Then when the patient gets sick and the doctor says, we're going to need this treatment for their melanoma, and the company says, well, have you tried this old-fashioned treatment that doesn't work? And the patient says, I'm going to go back to the old Medicare. That's called lemon dropping. The agents will frequently suggest that you switch back. The difficulty with that is getting supplemental insurance. The good price on the Medigap insurance is only available at age 66. An insurance company that sees you coming back with a serious illness is either not going to insure you, or they're going to charge you an arm and a leg for insurance. And so you can get the A and B, and then you can get the pharmacy without too much trouble, but without the supplemental insurance, sometimes that runs up a fairly big bill too. But at least you're getting care, and it's not as bad as with Medicare Advantage. This is an example of upcoding. So on the left, you have a 76-year-old woman who's healthy with no diagnoses, and Medicare pays $4,000 for that patient. Now, that patient's going to cost less than $1,000, so they're making a nice profit there. In the middle is a 76-year-old woman with two diagnoses. She's got diabetes and heart failure. So that now CMS, the Centers for Medicare and Medicaid Services, pays $9,000 for that patient. But there's a number of things that the doctor noticed she has, but didn't really think that it was appropriate to tell Medicare about it, because they were not things that were going to be needing money. But there are companies that specialize in upcoding. So you have somebody that goes over the charts and says, let's do everything we can to maximize how much money the government is going to pay the company. With morbid obesity, it's weight over height squared. So if you could lower the height, so you look through the chart and find the lowest height, sometimes you can maximize how the BMI. In this case, they got it up into the morbid obesity range. There were some eye findings that were probably there from aging, but they could be retinopathy, so we'll code it for diabetes with retinopathy. That episode of depression, they'll recode it as a major episode, a single episode, mild. And then the COPD and the asthma, it's typical for asthmatics to have hyperinflated x-rays of the chest and sometimes have a few growls and crackles. And so they code that as COPD, chronic obstructive pulmonary disease, rather than asthma. And that ulcer gushes down into the fat, so it's a stage 3 ulcer. So your risk score goes way up. The CMS is going to pay $32,000 for that patient. It's actually the same patient that they were paying $9,000 for, but it's upcoded. So you can see the gimmick that these companies are playing to try to maximize their. Now, how do you get a handle on denials of service? Well, in 2019, 500 charts were reviewed by a team of expert coders, experienced physicians, and 250 were denials for requested service, 250 were denials of payment for bills submitted for care delivered. So this team concluded that 13%, 1 in 6 prior authorization denials really actually met Medicare requirements and should have been paid, or should have been told that they can go ahead and get this done and that they would be paid for. 18%, 1 out of 8, that already had it done and were denied should have been paid. So their conclusion is Medicare Advantage companies are denying beneficiary access to service and denying payments to providers in an attempt to increase profits. So sometimes it helps just to go through a few cases. So the first one is a patient with a heart rate of 300. He calls the company and they offer him an intervention. But when he has it done, they refuse to pay for it. A physician, number 2, goes into anaphylactic shock, which means he got something like penicillin and his blood pressure dropped to 0. They resuscitated him, gave him epinephrine and steroids to get him back, and the company ruled it wasn't medically necessary. A patient with esophageal cancer was refused referral to a surgeon. I mean, it's obviously recreating the esophagus is going to be an expensive procedure. A post-stroke patient was told that she could regain her ability to speak with 6 months of speech therapy. The company agreed to give her 10 days. Cigna approved a patient at Vanderbilt for a double lung transplant for small cell cancer. A match was found. The match was available, everything was ready to go, and the company denied payment. So the surgery was canceled, and the patient died sometime later. Skilled nursing facilities all across the country have said that they lose $275 million nationwide of meaningful rehabilitation for seniors for every 1% shift from original to Medicare Advantage. And the same applies to healthcare and hospice. When I first came to Covenant Woods, the administration purchased a hospice and home health company thinking that we would diversify. But then with people going with Medicare Advantage and with the nurse shortage, we've ended up trying to sell those companies. Nobody would buy them, so we actually closed them down in the last 6 months. So. All right, so now we're going to go to the third type. This is the second part of my talk, the ACO REACH. So, accountable care organization realizing equity, access, and community health. It's a private corporation, so it's like Medicare Advantage, but they've added an accountable care organization underneath it. Now, accountable care organization is a new concept. It was first described in 2007. It never really has been researched. And in this context, it applies to a group of physicians and medical representatives, physician representatives, that are responsible for how the money is spent. So you have the private company taking out their share, and now you're going to have a group of physicians taking out their share and deciding who gets what treatment. So we talked about ACO as a new concept that's really poorly worked out. REACH is an acronym for several vague concepts. Equity, realizing equity is obviously desirable. The big problem with equity is the rural patients that can't get to a doctor. So this program is really not going to solve the equity problem. Most racial and ethnic groups have access to care. It's some of the problem is the physicians that are somewhat prejudiced, but for the most part, I think things are moving in the right direction. So it's not clear how REACH is going to prove that. And then access is about letting all seniors into the Medicare program. The big problem there is financial. The large number of people that can't afford to be in the Medicare program, and there's no way that this is going to help them. And again, community health. We have community health departments, so it's not clear what this is going to do. So let's look at how we got here. It's an evolution of a concept. So we go back to its origins. In 2018, a dorm mate of Gerard Kirshner was hired by CMS, Center for Medicare and Medicaid Services, to run an innovation department, the Center for Medicare and Medicaid Innovation. That department has come up with some good innovations. It was started under Obamacare in 2010, and it's given a $10 million a year budget. It's potentially should be doing a lot of good. This Adam Bowler, I guess is the way he pronounces his name, but he'd worked with a venture capital firm named Oxyon, so they hired Oxyon to see how they could undo fee-for-service Medicare and convert it to a Medicare Advantage kind of program. So the very thing up at the top there, what the motivation here is that the private insurance companies are making all this money on Medicare Advantage, and they see the other half of Medicare, the traditional Medicare, and they say, we'd like to make money on that half of Medicare as well. So they're going to try to take over all of Medicare under a Medicare Advantage kind of plan. So they come up with an ingenious plan, work through the physicians. After all, it's the physicians who send the bills. So if you can offer the physicians some enticements and just tell them, don't send your bill to the government, send it to our company. And CMS agreed to provide resources. So a physician who switches one of his Medicare, traditional, original Medicare patients to a Medicare Advantage kind of program, this ACO REACH, gets $30 a month for each patient, gets expedited billing. Billing is always delayed, and a 5% bonus on the reimbursement. He gets fewer quality reviews, protection against conflict of interest suits. I'm sure there's some other things I don't know about, but it all makes it attractive to physicians to convert. So that was the program that was started, and it was called direct contracting. So in 2019, CMS, Center for Medicaid Services, published a fact sheet, and they said this new direct contracting program is a set of voluntary payment model options aimed at reducing expenditures and preserving and enhancing the quality of care of beneficiaries in Medicare fee-for-service. So everything in that statement is wrong. It's not voluntary. Seniors are enrolled in the system without their permission or their knowledge in many cases. It's to reduce expenditures. Privatized care has traditionally cost more than traditional care, usually 5 to 10% more. So how it's going to reduce expenditures by privatizing it is not clear. and preserving and enhancing the quality of care. We've seen with Medicare Advantage that if you get really sick, your quality of care goes down dramatically. So you're not enhancing the quality of care. So in 2021, then CMS reported they had 53 companies that were out hiring physicians to be accountable care organizations. And in 2022, let's see, not 20. Well, the statistics aren't on here, probably on the next slide, but in 2021 they had 200,000 seniors signed up into their new direct contracting system. But the word started getting out. The program was causing a lot of headache. There were articles like "Stop the Plan to Destroy Traditional Medicare." So what they decided that the program should have been canceled, but instead of that, they changed its name. And they changed its name to Accountable Care Organizations Realizing Access, Equity, Access, and Community Health, ACO REACH, which is so confusing. In 2022, there are now 132 companies interested in signing up patients for this program. 20 of the 132 companies are private equity firms, and they're just really no experience in healthcare, but they're interested in getting in and making money. So now you have three programs. You have traditional Medicare with an administrative cost of 1.4%. So that takes $14 billion out of the budget. You have Medicare Advantage, which takes an administrative cost profit of 20%, about $200 billion out of the budget. And then you add ACO REACH, and your administrative costs go up to about 35%. By law, it's limited to 45%. So the amount of money available for care goes down with each iteration. Now there is something that needs to be said about accountable care organizations. In 2010, what did I go to? All right. Okay, let's skip one here. But, all right, let's go back. And so the difference between Medicare Advantage and ACO REACH is that the beneficiaries don't get to choose, and all of these controls that are in Medicare Advantage are not in ACO REACH. There's no cap on out-of-pocket expenses. There's no plan to choose from. There's no supplemental benefits that were offered under Medicare Advantage. It's not clear, but it appears that there's no pharmacy prescription coverage. So it's really an experiment to see if these private companies can really pull it off to take away most of the Medicare benefits. There is something that's confusing about accountable care organizations. In Obamacare, the Affordable Care Act in 2010, there was a provision made for something called the Shared Savings Program. And currently, accountable care organizations have 11 million beneficiaries and almost 600,000 physicians, 450 of these accountable care organizations. They keep traditional fee-for-service Medicare, which is good, because Bon Secours just went with the Shared Savings Program. I got a letter from my physician. What they do is they take an index year, usually before the pandemic, so 2019. So they take how much was spent on their patients in 2019, and they say we spent less money this year than we did in 2019, and the government pays them half the difference. So it's a way that these companies, let's see, so the estimate of how much is saved is about 0.5% of the Medicare budget, but recent studies have shown that it's really not saving any money at all. But it's nowhere near the 35% that's going to be taken out by ACO REACH. It's a small, something I was going to say, but all right. So we now have 3 programs. We have traditional fee-for-service, Medicare Advantage, and ACO REACH. So why would the Centers for Medicare and Medicaid Services want to do this? It's not clear. Trying to read between the lines. Many of the CMS administrators come from private healthcare firms, and they stand to go back and make considerable amounts of money having accomplished this. Certainly Wall Street is behind it. Anytime you have, and health insurance, the Medicare Advantage health insurance is twice as lucrative for these companies as any other kind of health insurance. So they want to get in on the business. So Wall Street's pushing for it. There may be a realization that the current system is going to run out of money. You know, we're increasing the number of beneficiaries, and it may be that they say, well, we'll set this physician group up, and they'll be in charge of telling people that their care is being denied. So I don't know. The physicians may be being set up. I don't know. And why haven't we heard about it? That's probably the more significant question. If an innovation is brought out by the Innovation Center, it doesn't have to be publicized because and Congress can't cancel it. So if you're bringing out an innovation and somebody's going to lose money because it's a better product, and they go to their congressman and say, "Can you cancel this?" It makes sense that Congress can't cancel it. And that they don't make a lot of publicity, but that seems to be the initial. AARP gets probably over 70% of their money from United Healthcare, which is a big Medicare Advantage company. So AARP is not going to publicize a lot about. They did have an article on Medicare Advantage recently, but they sort of skirted around the difficult issues. And I think many people remember what happened to Hillary Clinton when she and the Clinton administration said that they really needed to do something to try to reform the healthcare system. All of these private interests got on the warpath, and she was tarred and feathered. And that certainly affects my fears about standing up and saying a lot of this and getting VACCRA and NACRA to take a leading role in this. You know, we'll put ourselves up as a target. So what can we do? We can keep ourselves informed, watch webinars, YouTubes on this subject. We can contact members of Congress. There's the Congressional Hotline. Watch for letter writing campaigns. If you choose to write a letter, Martha Cole will be happy to help. Watch for and avoid physicians who joined ACO REACH. So if your doctor joins the ACO REACH, you'll get a letter that explains that. The only way not to lose your traditional Medicare in that circumstance is to find another doctor who's not in the program. It's very difficult at our age and station in life to switch doctors, but that's what's recommended. If your doctor's in this shared savings program, Medicare shared savings program, you can stick with them because they will bill and keep your traditional Medicare. There share stories about seniors who are harmed by privatized programs, and there are a lot of stories out there. There was a recent congressional testimony on this, and There was another letter that we'll probably talk about as well of senators and representatives talking to CMS and the government about these people that are harmed. You can carry the story into editorials, letters to the editor. Watch for action groups. The Physicians for a National Healthcare Program are publicizing the problem with Medicare Advantage and privatized care. Their overarching thing is that we need to reform the payment system for the whole healthcare. That there are too many pharmacy companies, too many large places like United Healthcare making too much money, and there are physicians who manipulate the system. Those physicians actually, if you put them all together, are a very small problem compared to the large problem of these companies making billions of dollars in profits. VACCRA is the Puget Sound Advocates for Retirement Action up in Washington State. They do a good job of publicizing this. There's something called the National Single Payer Program that I just learned about in the last month. And they've given some very good talks on this subject. So share insights, developments, data with others. On the right, the picture there says, "Keep your corporate hands off my Medicare." And it's that's a lot of. So CMS wants to eliminate traditional fee-for-service insurance-based Medicare. Their motivation is probably the profits for these big companies, corporate greed. It's certainly not to save money or to improve care. The more money they divert to private corporations, the more they profit. And these companies have lobbyists, money, and the will to subvert the system. And they're doing an excellent job of keeping the word away from us. The senior lobby is a robust network. If we can get all the seniors in the country raising the alarm, we have a good chance of reversing this. But it's the Biden administration signed off on that name change rather than nixing the system. And it was, somebody reported that the Democrats made $20 million off of these companies for doing that. So it's, I don't know, it's a very difficult situation, and people aren't doing a lot of talking about it. But so anyway, it's a good argument for why you need something like VACCRA and NACRA to pay attention to what's happening outside of Cedar Field or Covenant Woods. That there's a lot of things that our NACRA sent a letter to the Congressional Committee on Aging asking for another session to talk about finances and regulation in CCRCs. There are things happening that we need to pay attention to. So thank you.
Thank you, Chuck. Let's have time for a few questions. Does anyone have any questions? Bob?
I do. Chuck,
I'll repeat your question.
I'll say it loud enough. The upcoding that you're talking about, is that done by the companies or the physicians, and is it under the Medicare Advantage program?
It's Medicare Advantage, and it's done by the companies that are manipulating the physicians. So if they get the physicians to list as many findings as they can in the chart. They use artificial intelligence to go through the chart and come up with a list of possible diagnoses, and then the physicians say, well, is that reasonable to say that?
So I was 6'2" and now I'm 5'8", right? Yeah. Thank you.
Yes.
If I call my doctor's office and ask whether they're in this ACO thing or not, or if we want them to be in the MSS, whatever, P, if I just call and use those acronyms, who do I call and how do I trust what they say? Who's gonna know what I'm talking about?
You can call the office and ask them. I hadn't thought about that, but they should know what ACO Reach is.
And I have talked to people in my office, and they won't be able to whether they're in the experiment.
The question was, how do I find out if my doctor is in ACO Reach or something else? Okay, and so you call the business office, is that the answer, Martha Cole?
The office manager in your doctor's office will be able to answer the question. My doctor's office, I was dealing with somebody dealing with health and diet, and they knew they were on the program. Your doctor will know, and it's a 4-year experiment, and they're in the 2nd year of it.
Okay, so for those at home, you call your office manager, okay, your business office manager. Start there. Any other questions? Oh, yes, Charlotte.
You were talking about VACCRA and NACRA. We're very small compared to all the people who want us to get with the Advantage programs, who are going to Congress and paying them big fees and taking them out to dinner and drinks and all this to convince them that this is the program that everybody should be in. So compared to the Advantage programs, VACCRA is very small. Will they listen to us?
The question was, VACCRA and NACRA are small in comparison to these companies,
Yes.
Advantage companies. So how can we be effective?
Well, it's true. We have a limited number of people in VACCRA, and there are a limited number of states that have groups like VACCRA. So our impact as a group cannot be very great. And yet there's nobody really speaking the truth of what's going on out there. Martha Cole mentioned it's a 4-year experiment. I think what they're trying to do is to delay it long enough that they have so many doctors and so much momentum going that it can't be canceled. I think that's what the 4-year idea is. It's I don't know. It would be nice to think that we can cancel this some way. Certainly we can pay attention, and when we have a chance, these representatives and senators will listen to us if we start calling. So we can have some effect, but your point is well taken. My reason for presenting this is to try to get people aware and try not to switch to Medicare Advantage. If you've already switched to Medicare Advantage, probably you need to ride it out until you hopefully don't develop a serious illness. But in our age group, that often happens. So it's, and then if you do, you'll be forced to go back to traditional Medicare if you want to get the best treatments. And so I don't know.
You did mention that there's a Medicare Advantage PP, whatever it is. And I know that several people here have, through their companies they work for, they give them insurance, and those companies have switched from original, and University of Richmond's one of the groups that switched to a Medicare Advantage, but it's a PPO. And those people have seen no difference between that and original, but it's because they have a special program.
Yes, my wife has that. She retired from the city of Newport News, and I said, listen, you could get on traditional Medicare and I'll put you on my insurance. And she said, oh, but I earned this retirement, so she's stuck with it. And so far she's getting her medicines, and I think it's 80% of the Medicare Advantage programs have the drug coverage.
First of all, Chuck, it's good to see you and thank you for coming here. Personal story, I have a brother who's turning 90. He lives in a facility in Florida just like this. Some months ago, they had a speaker, I don't know who it was or where he came from, touting the benefits of going into an Advantage program. Unbeknownst to his children, my brother switched to his unhappiness. Fortunately, his children were able to undo that. But I encourage everyone to listen very carefully and consult with their insurance person or a loved one to make sure, before they make such a radical change, that they know what they're signing up for.
Yeah, you have to be careful of the insurance agents because they make a nice profit by switching you to Medicare Advantage. So you have to listen with a jaundiced ear that it's they may or may not be giving you the best advice. And watching the ads on the television, it makes it sound like Medicare Advantage is the invention of sliced bread.
Well, I think that we're running out of time here. So again, thank you, Chuck. It was very, very informative.